This presentation reports an analysis of the costs and consequences of different strategies for setting nurse staffing levels on acute hospital wards. This is part of a larger study to assess the validity and reliability of a staffing tool in widespread use in the NHS in England, as well as the potential impact of alternative staffing strategies based on the outputs of the tool. Funding was provided by the National Institute for Health Research, Health Services and Delivery Research Programme. This presentation reports independent research undertaken under this award. However, we should draw your attention to this disclaimer and make clear that the views and opinions expressed are those of the authors and do not necessarily reflect those of the NHS, NIHR, NetCC, the PHR programme or the Department of Health and Social Care. I also want to acknowledge the members of the Safer Nursing Care Tool study group, beyond those listed by name on the first slide as co-authors of this paper, since other colleagues within Southampton University contributed to the overall research. I would particularly like to acknowledge our partners at Trust who supported the research, contributing to the design and interpretation of the research, providing access to and supplying the data used in the analyses that are reported here. The next 3 slides give some background information on the overall study. The rationale for the study was derived from work undertaken for NICE as part of their review of evidence for the Safe Staffing Programme and incorporated into the HS&DR commissioning brief on measuring nursing input, workload, activity and care. The evidence review for NICE and other review authors have identified a range of approaches to setting nurse staffing levels, from pure professional judgment through patient volume and nurse staffing ratios, patient classification systems that have estimated staffing requirements for each group of patients, to task-based systems which base staffing requirements on time estimates for a list of tasks and activities required for the patient. Perhaps the most complex are regression-based approaches which derive staffing estimates using empirical models of the relationship between patient, ward and hospital-related variables and staffing levels in quality-assured wards. One unifying factor is a lack of strong evidence of effectiveness in terms of achieving quality of care or patient safety. We conducted an observational study of acute medical and surgical beds in 4 NHS hospital trusts using routinely collected ward-level data. Nurse staffing data came from the e-roster. Patient acuity was based on Safer Nursing Care Tool ratings recorded per shift in electronic systems held by the trusts. And patient volume bed occupancy measures were derived from the patient administration system. Using these data, we developed a simulation model to estimate the frequency of understaffing under different staffing strategies. These are described in detail in the next but one slide. And we used the outputs of the simulation model to estimate staff costs and consequences of the strategies. The Safer Nursing Care Tool, the SNCT, is a patient classification or prototype method which involves classifying patients on the ward into one of 5 acuity or dependency categories. Weights indicate the full-time equivalent staff requirement for a patient in each category. The sum of weights multiplied by the number of patients in each category gives the full-time equivalent nurses required to staff the ward, referred to as the establishment. The tool has been endorsed by NICE and is widely used in English NHS acute trusts. Approximately 80% reported using the Safer Nursing Care Tool to develop their trust establishments in a national study undertaken for another related project. And the Safer Nursing Care Tool is supported by a range of IT products. Guidance for the tool suggests that establishments should be set by taking one observation on 20 working days at 2 different times of the year and calculating the mean requirement. The tool provides no guidance on skill mix, that is, the mix of registered nurses and healthcare support staff, or the disposition of staff across the day and night shifts. We considered 3 alternative staffing strategies. What we call the standard scenario, which is the current system where staffing levels are set to the mean requirement. Then we considered a flexible or low scenario, where staffing is set to meet a low demand, with any shortfall on a particular day is to be made up by redeployment of full-time staff and use of temporary staff. The low level in this case was set at 80% of the mean. This figure was based on the NICE red flag, which defined a staffing shortfall of 20% or greater to be a noteworthy staffing safety issue. The high scenario, a high staffing scenario, was where staffing is set at a level to meet predictable fluctuations in demand most of the time. We set this at the 90th percentile of observed variation in demand. That is, we expected staffing to meet demand 90% of the time. In all scenarios, understaffing was defined as being more than 15% below the requirement. Understaffing was measured at the shift level rather than the day, and in any scenario, understaffing could be addressed by redeploying staff within the Trust Directorate and then by use of bank or agency staff. For the base case, we constrained availability of bank and agency staff to fill these short-term vacancies to be at the level observed in study trusts where we could obtain the data, which was in only one trust. This slide shows the simulation results, and the majority of the results here and in the economic analysis present the flexible low and high scenarios versus the standard, as the standard is the current standard approach against which you should be considering any alternatives. So compared with the standard approach to establishment setting, establishments were 10% larger in the high scenario and 20% smaller in the flexible or low scenario. The effect of these decisions in terms of frequency of understaffing was that 19% of shifts were understaffed in the high scenario, but 63% of shifts were understaffed in the flexible scenario. These both compare to 31% of shifts being understaffed for the standard approach. In terms of cost, across the 4 simulated trusts, staff establishment costs were £11 per patient per day higher in the high scenario and £15 per patient per day lower in the flexible scenario. That is the situation where availability of temporary staff is based on current empirical availability. If we increase the availability of temporary staff, the cost saving for flexible low approach over the standard almost disappears. It's down to £3 per day, but with 21.4% of shifts still being understaffed. For our economic analysis, we adopted a relatively simple baseline model, which allowed for increased mortality risk and longer patient stay as consequences of understaffing. In an additional analysis, we allowed for increased risks due to the use of high use of temporary staff to offset understaffing, increasing the risk of patient mortality or increased stay above that caused by understaffing alone. Now, we recognise that there are other risks associated with understaffing or use of temporary staff, but we did not have reliable risk estimates to apply these other potential risks in our analysis. Staff costs in the economic analysis were based on the establishments from the simulation model using grade-specific unit cost for full-time staff, weighted for agenda for change on social hours allowances. Bank staff were estimated using a modified unit cost, and agency costs were derived from the agency cap values, indicating the maximum spend for hours of agency staff. The consequences in terms of patient outcomes were based on patients' average exposure to understaffing and estimates of the relationship between understaffing and mortality, as well as length of stay derived in our previous study in one of the trusts. This figure shows a summary of the baseline analysis, which allows for redeployment of staff within the trust and use of bank and agency to cover understaffing. Staff costs in the high scenario increased by 5.5% over the standard, while they were reduced by 10.8% in the flexibly low scenario. The high establishment scenario is associated with a 1.2% reduction in bed days and a relative reduction of 4.5% in the risk of death. In contrast, the flexible low establishment is associated with a 1.7% increase in bed days and an 8.3% increase in risk of death. To estimate the impact of these changes in risk of death, we applied these to the baseline mortality experience at the 3 trusts included in the analysis. Averaged across the 3 trusts, the number needed to treat to save 1 life in the high scenario is 670 patients. That is, 1 life saved every 670 patients treated with the high scenario establishment. And the number needed to harm of 360 in the flexible low scenario, i.e. 1 additional death per 360 patients attributable to inadequate staffing. Expanding these analyses, we estimated a staff cost per life saved of £20,423 and a cost saving per life lost of £22,910. If we allow for the value of the change in bed days, these estimates reduce to £9,506 per life saved in the high scenario and a reduced saving of £13,967 per life lost with the flexible low staffing. The difference between scenarios are hugely reduced with more generous assumptions regarding the availability of temporary staff to cover understaffing. table in this slide repeats the data presented for the baseline analysis on the second row with the figures showing empirical availability of temporary staff. If the availability of temporary staff increases, you can see that the cost difference in terms of the flexible or the cost saving with a flexibly low scenario compared with the standard reduces, and the excess risk in terms of mortality reduces, but in no situation does it completely disappear. The estimates presented so far don't take account of any possible effects in terms of reduced staff productivity or patient impacts of reliance on temporary staff. If we allow for risks associated with substantial exposure to temporary staff, the kind of levels that were estimated in an analysis of our study showed a level of 1.5 hours per patient day or more of temporary staff might lead to increased mortality. Including this in the analysis indicated an 8% increased risk of death at the maximum availability of agency staff in the flexible low scenario. We conducted sensitivity analyses for a range of input values, including the effect of low staffing on mortality, the cost of additional bed days, and costs of a range of staff. The estimates were most sensitive to the assumed effect of low staffing on mortality. If we consider these results and the implications of these findings at the trust level for the 3 trusts that were included in the study, and to give some idea of those trusts, they covered between 600 and 1,100 beds with turnovers ranging from 250 million to over 800 million. Adopting the high staffing scenario would correspond to a less than 1% increase in turnover and may avoid between 50 to 130 deaths per year. So in conclusion, employing sufficient nursing staff to meet demand most of the time is more expensive than current standard practice, but is likely to save lives. It's likely to achieve this outcome at an acceptable additional cost in financial terms, less than 1% of turnover for an NHS hospital trust, and at a value less than £30,000 per life saved. Employing a minimal safe establishment, supplemented by redeployment and temporary staff, may be cost saving, but achieves this at substantial risk to patients. Increasing use of temporary staff to cover shortfalls increases costs, substantially reducing the saving, but does not eradicate the risk to patients. Employing temporary staff at this level may not be possible or financially sustainable given current pressure to reduce agency and limited access to bank and suitably qualified bank staff. It should be borne in mind that all these scenarios assume that staff can be recruited to fill the posts. Thank you for listening to this presentation. Please add questions or comments below this presentation. We'll read and respond to them. If you'd like more information on the project and any other analysis that were undertaken, please follow the link to the final project report, which is available at the NIHR website in the HSNDR journal series. And we show the link on the final slide. Thank you very much.